I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about female pelvic health, sexual health, and reproductive medicine. Before I get into it, a few things I want to make very clear. One thing is that this is not meant to be any type of medical advice. So if you have any questions about your health, make sure you go speak with your healthcare provider. And this is not meant to be any advice at all on religion. So if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I have on with me Dr. Rachel Pope. I'm so excited to have you on, Dr. Pope. If you could introduce yourself to the viewers and listeners out there that may not know you.
Sure. Thank you so much for having me. So I'm Dr. Pope. You can call me Rachel. I'm a gynecologist, and I did a fellowship in global women's health. So I spent 2 years training to do obstetric fistula repairs, so complex birth injuries for women who needed C-sections but were living in a place where they couldn't get one in time and ended up with severe pelvic floor, vaginal, bladder injury. I continued doing that work for 2 more years in Malawi in sub-Saharan Africa and started to see how much their sexual function was impacted from the initial injury, then from, the surgery, and started to realize how much I had missed out on incorporating this into my gynecological practice, even in the US. So now I'm back in the US and I'm still doing complex reconstructive surgery for women, but really focusing on sexual function, which has led me to focusing also on menopause, which I wasn't expecting, but I love. And that's kind of me in a nutshell.
That's fantastic. I didn't know that about you. That's amazing. Yeah, I was a few years ago, was in touch with this urogynecologist out of Einstein here. And I think her name is Dr. Fleischer. But anyway, so she had also done a lot on fistula repair in Africa and things like that. And so that's amazing work because that
Thank
is so
you.
needed. And, yeah, there's a lot there. So,
Yeah.
but that, we're going to get into that. So, absolutely. I mean, there's so many women that throughout the world, don't have access to healthcare, as you know from firsthand experience. But, I did some medical missions, one actually in Pakistan, and we worked with lay midwives and teaching them just, basic ultrasound about like position and fetal lie and things like that. And then we gave them, a couple of lectures on like shoulder dystocia and hemorrhage and things like that. But, it was these women, they do amazing work and they're not officially trained, right? They're like lay
Yeah.
midwives. They
Like
go and help women
apprentice
out in
style
the
learning,
field.
right? Yeah.
Yeah. And they, they see women at least like they were saying when we were talking to them at least once a week that have like anencephaly, right? Because they don't have
Wow.
folic acid. They
Wow.
they have women that will die after, childbirth because they're
Yeah.
so anemic. They come in, with hemoglobins of like 4 or 5 and things like that. So it's, global health is just, it's one of my passions. So,
That's awesome. Yeah, and we just kind of forget how the rest of the world is living, and so
yeah.
it's awesome that you've done that work. It's really
Yeah,
cool.
yeah. But, so tell me a little bit about, your work. So you said, you started to work, in sexual medicine, after you started doing the fistula repairs and so you talked a little bit about that. So I'd love to know a little bit if you have like a patient story in your career that shifted your approach to like menopause and sexual well-being.
Yeah. I mean, the main patient who really influenced me is not my patient, but my sister.
Oh,
She was going through a uterine leiomyosarcoma diagnosis,
oh my
and
goodness.
I
That's
know,
so
really
rare.
aggressive cancer, and she's doing great today. She's
That's
battled
great.
for many years. But when she was really going through the thick of it after surgery, going through chemo and went through sort of instant menopause, because of the treatment that she needed to survive, she started asking me these questions about menopause, questions about really basic gynecological issues that, again, I was like, oh my my gosh, I'm not even sure where to get started on this. And
Yeah,
it's such
yeah.
a important quality of life
Yep.
element that, again, I realized I needed to educate myself. And so
Yeah.
that was a big turning point for me. I think her experience, and then also what I had been doing abroad, it was around the same transition point. I was moving back to the US and I had been taking care of so many women who had these complex, vaginal issues and were trying to be rehabilitated for their own sexual function. And then coming back to the US to kind of be closer to family and illuminated by what she was going through, that I realized, wow, there's this whole other part of gynecology that I need to learn and I want to incorporate into my practice.
Yeah. And, you're so right because once we start, and this was so close to you, this was so personal, right? It's your
Mhm.
sister. But, so many times there were times in, practicing, I've been an attending now for 21 years. And, just to your point of like not knowing where to start, right?
Yeah,
Like you meet patients that, let's say, are experiencing low libido, or they're experiencing pain with sex, or they're experiencing so many things. And if you're not taught, you
yeah,
feel almost embarrassed. At
that's
least I
exactly
did
right. Me too.
as a,
No, I did too.
as,
Yeah.
as a physician, not having, like patients come to you for answers and you're like,
Mhm.
I don't know the answer to this, and
Yeah.
then it tells you where maybe perhaps in our own training, there were some shortcomings. And
Yeah.
so
Yeah.
we
I
have
mean,
to really
this
make
is kind of what's gotten me interested in research so much. I've always loved research as part of my training. I did a master's in public health. So I've always kind of had this like research lens along with my clinical lens. But I feel like when I get to these situations where like my sister asked me these questions or my patients ask me a question, and if I realize I don't know, I mean, sometimes it's because I literally, the information's there and I just wasn't aware of it, right? But
yeah,
more often, especially in our field of female sexual
yes,
medicine and menopause, we don't know because nobody's done the research.
yes,
And
yeah,
so
absolutely
starting
right.
to like look into, oh my goodness, if this is affecting this woman, it's probably affected so many other women, and yet nobody has sat down to do this research to answer this question.
Yeah.
And there's a massive field in front of us of opportunities where really I hopefully more and more people listen and kind of are diving into this work and finding areas where they can contribute, because you and I can't do it alone.
Yeah, no, I mean, I think that women's health, right, has just been so it's lagged behind men's health for so long. And we just don't have the research. We don't have it. But there's great people like you and Rachel Rubin and everybody, doing the research. So I'm so grateful for all of you.
Thank you.
So now, how do you balance the evidence-based medical side with the emotional complexities women, bring in with sexual health conversations, especially because in so many cultures, I mean, I'm sure you see this, especially when you were in Malawi, right? So many cultures, I mean, there's such taboo and stigma and shame, and especially with the field that you were doing with fistulas, right? I mean, people, I mean, I've watched so many stories about this, and you experienced it firsthand, is, women just afraid to leave the house, right? Their sexual function suffers, their relationship with their family suffers, their community, they're just, because they smell, they don't know how to get that help. And I'd love for you to talk more about that. Yeah.
Yeah, I mean, I see so many parallels with fistulas, although I know it's such an extreme example, but I see so many parallels with that and women, even in the US, who are going through issues with their sexual function or issues with menopause, because the underlying theme for all of them is that either there's a lack of understanding of what's going on with their body because there's this taboo about women's bodies, so that even the women themselves aren't 100% aware of what's going on. And then second of all, there's this like shame that they're not supposed to ask anyone for help. They're supposed to kind of just get through it on their own. And so I think of, okay, wow, we are ill-equipped to understand our bodies because there's a taboo, and then we're supposed to be ashamed to ask for information when we need help. So like we're just literally stuck. And so whether you're dealing with a fistula that's left you incontinent after childbirth, or you're dealing with, painful intercourse, not feeling like yourself, not sleeping well, having hot flashes through the night, and feeling off, like in all of these extreme scenarios, I feel like women are just kind of told to stay quiet, stay in the dark, and like get through it. And I just don't know how women can be expected to do that. I feel like we have information, we have treatment, and the more we can convince people to talk about it, the more we can apply that evidence that you mentioned before. So, like, there is this huge emotional component and maybe cultural component that we have to find a way to overcome while still allowing for people to stay private about their intimacy, to stay private about things that they might not want everybody else to know about, right? We've got to figure out a way through that in order to get them treatment that's going to change their lives.
Huge, yeah. And I've been saying this a lot lately because I really believe it's true, is that women have been cultured to accept pain,
Yeah,
right? Like
yeah,
we have they're just expected to like just be like, well, that's just part of aging or growing up or something like that, right? Like in puberty when you first get your menstrual cycle or during, every single month when you get your period, right? I used to have like horrible periods. Women that have endometriosis, women that have fibroids, then child labor, then contractions with that, then like perimenopause, and then menopause when you start to have pain with sex. And I think women are just expected to like just deal with it and not talk about it. And there's such that, well, you just kind of, plow through it. It's not a big deal. It's just a form of aging, but it's not. And I think that and I think this is what's so great about social media is that because people are loud, because people are talking about it, because women are being told now that, listen, you don't have to deal with this. There are solutions. And I think before social media, it was perhaps harder to tell people that there are solutions. And then we
yeah,
didn't, like
exactly.
I can say that I didn't know myself, that there
Yeah,
were solutions. Um,
yeah,
but
maybe that's
now,
it. Like social media really just helps to bridge that intimacy thing and that area where people are
yeah,
nervous. It probably started with Google, right? Like you're
yeah,
nervous to talk to your
yeah,
doctor or your healthcare professional about it, but you could Google it, and you might not find much information or you don't know what information to rely on. But then we've now gone a step further with social media to find professionals like yourself and our colleagues who are out there trying to put out good information on things that people are maybe a little bit nervous to speak about. And I'm sure you see this every day like I do when so many women who've been going through the difficulties of pain, whether it's endometriosis or even postpartum depression, and then they get the gumption to bring their concerns up to a healthcare professional and then they're dismissed, and then
yeah,
how many years it takes
yeah.
them to get the
Mhm.
gumption back up again, to find
Yeah,
someone who actually can help them and validate them. And
yeah,
so I hope that social media is like shrinking that amount of time and sort of doing that work to get information out on a larger platform so
yeah.
people aren't suffering but
I
in silence.
I agree with you 100%. So this podcast actually is global, which I'm so proud of.
Awesome.
It's
That's
There are
awesome.
50 countries throughout the world that download this
Cool.
podcast,
That's great.
and outside. So the U.S. downloads it the most, and then India downloads it
Oh,
the second most.
wow.
And it's usually like neck and neck. But the reason why I bring that up is because, to your point of like getting the information out, right? That it's so important for people to know that they don't have to suffer and that there are treatments, and then, that there's hope that they don't have to live with, let's say, like a fistula or pain with sex and menopause, or, what can they do for endometriosis? What can they do for fibroids? All of those things that's so, so important, that they may not have had access to before. So many women describe, perimenopause as changes without warning. What are the first sexual health related changes that you see emerging in, let's say, perimenopause?
Yeah, I see change of desire or decreased desire
Mm,
probably sneak
yeah,
up on people first.
yeah,
It's almost, I also see women start having vaginal dryness and pain, but I feel like sometimes that shows up a little later and desire is the earlier one. There's probably it's multifactorial, right? So if you think about your typical perimenopausal woman, maybe 43, 44 years old, what's happening in her life? In our context in the US, that's kind of my typical patient. And she usually has young children, aging parents, a full time job, a lot of stress.
Yeah.
And when I ask her, when she comes in to talk to me about low desire, and I ask her, when did it start? She might not even really be able to pinpoint it because it's kind of snuck up on her. She's busy. And what has driven her to actually come in to ask for help is usually the strain it's taking now on her relationship. Like,
Mm,
she didn't notice it. She was so busy. Life was kind of happening. And then she and her partner realized, okay, they're not connecting on this level. And it's because it's not crossing her mind, or she's just has, honestly, what I hear most often is people just would rather sleep. I don't know if you hear that too. They're like,
yeah.
right, like the end of the day, they're finally getting to their bed and they just want to sleep. And they're
Yeah.
not thinking about sex and or intimacy unless everything else is optimized, and so
Yeah.
hard for everything else to be optimized for that particular person. So I see that showing up, and then close behind, I see, vaginal dryness and pain, because of course, if something's not feeling good, then the person doesn't want to engage in that. And so it could even be subconscious that the low desire follows that discomfort.
I
Um,
think that's, yeah, go ahead.
no, and then more rarely I'll see like lack of orgasm or difficulty with orgasm, and that especially starts to show up after menopause. But I guess if we're talking about perimenopause, probably the first thing that shows up is low desire. Do you find the
Yeah.
same thing, or what do you see?
Yeah, yeah, I would say, I think that so much of what you said definitely resonates. I think that a lot of women are in that sandwich generation that you're talking about, right? Taking care of aging parents, and then also, taking care of their kids, and there's just not enough time. I think that when sex becomes a chore, and it's just one of the things on their list of things to do, I think that they're not going to want it. With Emily Nagoski and, Esther Perel, I'm sure you've heard this too, is that to want sex is to have sex worth wanting. I think that, also with like, if they're not experiencing pleasure, right, in the relationship, if like with all of those things that you mentioned, right, pain with sex, vaginal dryness, problems with orgasm, you're not going to want it. I just had a patient tell me the other day, she's like, when I have sex with my husband, I don't feel anything at all. I just lay there like a zombie. I just want him to
Oh, that's
finish.
so sad. That's so
Yeah,
sad.
right? So I think that, I mean, a lot of times women don't know, like, what's going on in terms of like what they can get for help. Like, how can they help themselves? How can they help their relationship? And, this in my podcast, I talked to a lot of fantastic individuals like you. And, I talked to recently, I had a conversation with Lori Barato. I'm sure you know her as well. I love Lori. And she has that book, and I tell everyone about her book about better sex or mindfulness. And, so then I start talking to people, and I'm also a sex coach. So I'll start to talk to people about like, if they think about what are they thinking about, and a lot of people, I had a patient actually the other day who had, she has a lot of like issues with sex. And she said that, it started when she was younger, like a child, I think, and she said it wasn't trauma or abuse, but it was something else. And she didn't want to get into it, but she carried it with her so she's still carrying it with her. And she finds it very difficult to talk about. And, she wants to talk about it. She starts the conversation with me, but then she'll shut it down and she'll be like, no, I'm not ready. So I feel like, there's so many aspects to libido. And I feel like, just in sexual medicine that we always talk about is the biopsychosocial aspect of it, right? We look at the biology of what's going on. Then we look at psychologically, do they have anxiety or depression or any other psychological issues? And then we talk about the social aspect, right? Like trauma, abuse, is there sex negativity? Did they grow up in a culture of a lot of sex negativity? And so I think putting it all together really,
Yeah.
really helps.
Yeah, and I think orgasm is a really hard one. It's one of my favorite areas to help people with, because I love to quote this. I mean, it's sad, but there's like 10% of women who will never experience an orgasm, and how many women who basically in perimenopause and menopause, once all these things start to become more difficult, have still not experienced an orgasm. And so I really love when people come in seeking help to be able to experience an orgasm, but it is a tough one because we know there's medications that can decrease orgasm, but there is also this whole psychological component, and for a person to feel comfortable with their body, right? And for them to kind of allow all of these other things to work out if physically there are no physical problems. And I do, I work with two amazing sex therapists from the OBGYN department and a sex therapist in the urology department. And the three of them together help my patients so much. But it really does take this like combination of the physical sort of medical aspect and the psychological aspect to really help people figure out that quality of life for them.
Absolutely, absolutely. And I love how you pointed out that some people are just not comfortable with their bodies, right? And I think that it starts from childhood, right? I think that there's a lot of shame, that is instilled with children about not, talking about their bodies or, private areas and things like that, and their genitalia and things like that. And then I think that if children and the parents don't know, and I think that one of the best things that one time I had a conversation with my mom, and I was just saying to her, I was like, you know what, you never told me about, I don't know, like menopause or stuff like that, whatever. And she said, but nobody told me, so how could I tell you, right?
Oh, that's right.
So
That's right.
I think,
Yeah.
yeah, so I think that same thing with our bodies, right? Like if nobody has told the parents or taught the parents that, that you should look at your body, you should know what you have, you should know, all this stuff, then there, I think that stays with the child and then it comes into adulthood. And I feel like that is a lot of times what leads to like the sex negativity, right? Is that you're not sure, you're not comfortable with your own body. And I think that to your point, is that maybe we just don't allow ourselves, right? Give ourselves permission, but even allow ourselves to experience pleasure because in our head, maybe we're thinking that it was always wrong, you
Right.
know?
That's right. And I think there's this issue with protection, and it's an issue because I don't know the solution necessarily, because we do have fear around our children's bodies. I mean, I'm a mom of three girls, and I want to make sure that they're safe, and trying to figure out how to educate them about sex while still like keeping them safe from sexual predators is a quandary, right? It's a challenge, but I do think there's evidence to show that if girls know what their anatomical parts are, they can communicate to healthcare
Yes,
providers
absolutely.
better and sooner if they are being harmed. And so
Yes,
we have to kind of figure out how to get through this kind of dark and cloudy scenario of fear. And really, we do need to protect our kids. It's not a fake need. We do need to protect our kids, but protecting them is also teaching them and empowering them. So I think that at least to tell parents out there is a big deal, so that they know, educating them is not going to harm them. It's going to help them.
absolutely. Absolutely. Yeah. And I think that, and that's part of the reason why I do this podcast. For me, it's all about education and empowerment, right? And then I think that once people have the education, then they can feel empowered, then they have more agency over their bodies and can make, educated decisions about their own bodies. And I think that that's one of the most important things. So, what about changes in arousal and lubrication and orgasm that are physiologic versus hormonal versus brain
Mhm.
based?
Yeah. Oh, it's a mixture, right? So I have patients who have gotten started on a new medication, usually an antidepressant, and that's where we start to see arousal changes. So the desire is there, but they can't get aroused once they start to engage, and then that leads to lack of lubrication. We do see other things. There could be like pain with the clitoris, which could be from different nerve issues or an injury or those keratin pearls that can get stuck underneath the clitoris. I see this after childbirth as people are trying to kind of get back into what their functioning was before and realize their body has changed, or they're still breastfeeding or pumping, and that really still changes the physiology of their genitals. And so they can't get that arousal or lubrication easily, and they think something's wrong with them, right? But we know that things will get better. But there's a array of things I think that interrupt the arousal and lubrication process for people. And I usually try to reassure my patients like the fact that you have the desire is a great starting point. And so now we can kind of figure out, and it's kind of detective work to figure out what has changed now. Sometimes it's thyroid issues that we can see affecting women. But I'd say most often what I see in practice is a new medication.
Yeah, yeah, absolutely. And so, what is your best explanation to a patient about, let's say, estrogen receptors in the vagina, the bladder, the vulva, and how declining estrogen affects sexual function? And I would add to that, even testosterone receptors, right? We see that.
Absolutely. Yes, exactly what I was going to say. So we know there's
Yeah.
estrogen receptors and there's also testosterone receptors. And so we need to kind of keep that in mind, not only during perimenopause and menopause, but also during those early, the first year postpartum. Because if you are breastfeeding or if you are on, some birth control pills even, and some spironolactone or like things that you're taking for acne or for hair loss, and you might not even be as connecting the dots, those can decrease testosterone that's circulating and then decrease the amount of testosterone that you have in the vagina and the vulva. And then all of those other conditions like breastfeeding and being perimenopausal and postmenopausal can decrease estrogen. And so we've got these estrogen receptors and these testosterone receptors that are basically just kind of hanging around waiting for something to
Yeah.
come help them. And if we're not getting them through our bloodstream, then it's so important to give them those hormones through a topical cream or a tablet or something that we can get into the vagina and to the area of the vulva. This area between the vulva and the vagina, the entrance of the vagina, the vestibule, is what really causes pain for people. And so that's what I hear most often for women is, everything was fine. And then I started having pain with the beginning of intercourse, just with that entrance of penetration. And so that's because the vestibule is being affected. And they say that once they get past that point, it's okay. But just imagine any activity, if it's that painful in the beginning, what's really going to convince you to keep going, right? There's got to be, hopefully, she's also then able to get aroused and have an orgasm. But for a lot of women, they can't because that pain is so severe that they're like, okay, just get it over with, right? Like your patient who said that she kind of lays there like a zombie. I hear that a lot for patients who say they just want their partner to get it over with because it's so painful in the beginning. Or that pain in the beginning makes their pelvic floor now respond and tense, right? And then how many women you've seen that we see that who have all of a sudden pelvic floor muscles that are hypertense and cause even more pain. And so these women tell me it feels like my partner's hitting a wall and I didn't have this problem before. And we can kind of take it back and realize it was because of the changes to the vestibule, the entrance of the vagina, that then started the pain. And then secondarily, her muscles started to spasm or react to brace herself for the pain, right? And then you can get trigger points, all of these other things that cause worsen pain. And then who's going to orgasm in that scenario, right? It's just like it's a domino effect. One thing
Yeah.
affects the other, and it's great, if you can get in with someone who's got expertise with sexual medicine. We see this often enough, these patterns that we can start to figure out where to intercede and make them go away so that you don't have pain with intercourse.
Yeah, absolutely. Absolutely. Yeah. And that's what I was thinking about when you were talking about the vestibule. I was thinking about the vaginismus and, all of that pain that starts up. I actually had somebody that called me from Michigan about a few, I don't know, maybe it was last year now at this point, but she had seen one of my TikToks and she reached out and she thought I had an office there, but I don't. But, her thing was is that she was not able to have, vaginal penetrative intercourse with her husband for 8 years. 8 years, and she'd, been looking for some help and this and that, and I was like, I was impressed that they were still married,
I know,
I
right?
couldn't
That's
believe it. Yeah,
amazing. That's
yeah.
testament to their love for
Yeah,
each other.
absolutely, but, it was very difficult for her, and, I just hope she hopefully found some help, but, she wanted to get an exam and this and that, and because I don't have an office there, but yeah, I mean, so difficult, right? Some people struggle for so long. I had another patient that was a pediatric cardiologist, same thing. It had been a year and she wasn't able to consummate her wedding, and I think that even though we think that perhaps it's, due to lack of education or whatever, that people don't know what's happening, but, here she is, she's a pediatric cardiologist and having a lot of pain with intercourse and she knows what's going on, but she still is not able to have it. So, I think that's why I think that it's so important for patients,
Yeah, it
to
is.
have
And we have tools now, right? So like
Yeah.
we've got vaginal estrogen, or you can get estrogen and testosterone compounded, or you could get intrarosa, one of my favorites,
Yes.
prosterone. So it turns into estrogen where you have receptors and it turns into testosterone where you have receptors. And then we've got amazing pelvic floor physical therapists that can work on
Yeah.
the muscular part. I think, 20 years ago, maybe we didn't have as many tools. And so nobody should be going for 8 years with painful intercourse. And
Yes.
I'm hopeful. I'm so glad to hear that your podcast is global because I do think that there are countries where there's more sexual medicine focus than others. And so
Of
if people are
course.
listening and they're in places where there isn't that much focus,
Yeah.
these tools are not high tech. It's
Right.
not like this is something that's difficult to translate to another country. And so hopefully they'd be able to get the help everywhere that people are listening.
100%. 100%. So when women present with low libido, we
Mhm.
talked a little bit about this, what is the real issue? I find that there's a lot of issues that come up, right? I think that there's a lot of resentment, right? On both sides, depending on who has the lower libido or, who really defines libido. I mean, like, who says that one is high and one is low? And
Right?
tell me what you see and what you
Yeah.
find.
I mean, you mentioned Esther Perel before, and I love her book, Mating in Captivity. And I recommend that to a lot of my patients who start to notice decreased desire and they've been in relationships for 20, 30 years. And we kind of talk about, I think I might not be exactly quoting her, but she says something to the effect of the opposite of eroticism is routine.
Mhm.
And
Yeah.
when you are in a long-term monogamous stable relationship, it kind of becomes routine. And
Yeah.
for a lot of people, their intimacy becomes routine too. And so sometimes I see that contributing to low libido. Sometimes it's the life factors, but really more often I see that it's menopause, and I think it's because of the decreased testosterone that our ovaries are producing. I had a patient not that long ago come in to see me. She's in her 70s. She's kind of recently remarried, so she's in a really exciting new relationship. So that routine thing was not part of the problem. But she had a oophorectomy. Both of her ovaries were removed
Mm.
surgically, and there was a concern for cancer. It was like a cyst that she had, and that's why they were removed. And at her age, in her 70s, most people wouldn't hesitate to remove both ovaries because they're in the abdomen already. It's not a surgery without risk. So people say, okay, well, we might as well take both ovaries if we're not
Mm.
expecting to get any benefit from having them
Mhm.
there. So she had both ovaries removed, and she came to see me because she said that after surgery, when she recovered, her libido was gone. She's
Wow.
like, the only thing that changed was that her ovaries were removed. And, from my education as an OBGYN, I have had no training that has said that the ovaries are useful for libido at that age.
You're
You know,
right.
there's
Right.
nothing.
Of course, yeah.
I wouldn't have, if I were the one operating on her, I probably wouldn't even counseled her on that risk. In her 70s, but she noticed the stark difference. And
So
so
interesting. Yeah.
right. And so I think
Mhm.
that we have so much to learn and so much yet to understand about the ovaries. But, that's kind of an extreme case, but I do think that the ovaries are really important for releasing testosterone. And maybe the other hormones are part of it too, but I do think testosterone is the biggest one for libido, where I see if we give women testosterone back, their libido often comes back too.
Hmm. So did you start giving her, testosterone?
Yeah, did.
Yeah.
So it's too recent to know how she's
Yeah.
doing, but I really hope for her sake that
I
things come
know.
back.
That's
She wasn't having pain. She wasn't having difficulty with the orgasm.
amazing.
It was real. It was just desire.
Wow.
Yeah.
That's fascinating, and I'm so happy for her that she wasn't having any pain or problems with
Yeah.
orgasm or any of those other things, hopefully her
Mhm.
libido comes back.
Yeah.
So, what is your clinical approach to evaluating, let's say, sexual symptoms before prescribing hormones?
Mhm. So if we're talking about systemic hormones, I don't necessarily have to do a physical exam for a person. It's really about their history. There's so much information in a person's story that can help me to try to figure out what it is that they need. But if it is something physical, then I do need to do a physical exam and try to see, is there pain? Is there something going on with the clitoris that's causing their pain? Is it something at the vestibule? Is it something with their pelvic floor muscles? So I feel like two areas, just really listening to a person's story to understand what it is that has gotten to them to where they are today, and doing a good physical exam to really look at the areas that are involved is so important. So that's usually where I start. And then I had mentioned earlier, a lot of times I see changes because of new medication. So making sure that I understand what changes have happened and trying to figure out the timeline of that is kind of where I get started.
Yeah. So, I'm curious what you think about, we talked a little bit about testosterone. What do you think is missing from like the current research to make FDA approved testosterone for women? I mean, I just hope that one day we have that. I don't know if we will,
Yeah,
but
I do too. The only thing that I worry about is that once we do get a prescription for testosterone, it's probably going to be so expensive.
yeah,
Like
yeah,
right
yeah,
now, we use
absolutely.
testosterone by giving women the male
Testing. Yeah.
prescription, and it's a
Mhm.
fraction of what the men need. And so it's actually not terribly expensive, although it's off label, so it has to be paid out of pocket. But I was thinking about this the other day. Once we do get an FDA approved testosterone, and I'm sure we will, it's probably going to be crazy expensive for
Yeah,
women and
yeah,
still have a barrier because that's just
yeah,
what happens for all
yeah.
all medications for women and for women's intimacy, especially. We do have two FDA approved medications that I prescribe a lot for women, both flibanserin and bremelanotide. And
Yes.
they're a challenge to get to women postmenopausally
Awful.
because,
You
right?
can't,
Because
they
it's off
never get
label.
approved. Never.
Yeah,
I'm
they're not approved.
tired of the
Yeah,
rejection. I'm like, this is,
exactly.
and
Well,
they're
they're
so
considered.
expensive.
Exactly.
To pay
I
out
mean,
of
the
pocket.
FDA, for some reason, decided to like separate premenopausal women from postmenopausal women. And I'd like to again point to the men's health. And there's no separation of a 30-year-old man to a 70-year-old man when it comes to looking at Viagra or Cialis,
Right,
right?
right.
So, like, why when we have research that shows that things benefit for all women of those ages regardless of menopause, are we not FDA approved for both? So yeah, so it's off label in the US for both of those medications for women after menopause. So if they want it, they have to pay out of pocket, and it's not cheap out of pocket. But for my perimenopausal and premenopausal women, I do prescribe those two medications a lot. I think bremelanotide is way under prescribed. I think it's a great medication if you can avoid the nausea with like a
Zofran.
antiemetic or a
Yeah,
Zofran or something. It's
yeah,
usually how I prescribe it. It's such a nice medication because it does go out of your system, so you can literally just try it, and if you don't like it, that's it. And if you do like it, then you can use it. You can use it again, and it's a great tool for women to be able to have. I think flibanserin also helps a lot of women. It's harder for me to convince them to try it because I think, it takes 4 to 6 weeks to start working. A lot of times women notice a difference, but it's not as drastic a difference. So I think it takes a little bit more commitment to try it. But I do think that those two medications are really great tools that we didn't have, again, 20 years ago.
yeah. I find it so hard to get like to all the prior authorization. It's such a pain, right? All the prior
Right.
authorization,
Yeah.
and then in the end they tell you, nope, we're not going to
Yeah.
pay. It's just,
Well, I think insurance just wants us to give up, right? Like they're just banking on us giving
yeah,
up.
yeah,
So I know I've got great support in my office to help me with the prior
yeah.
authorizations. That makes a big difference.
It
But yeah,
does.
for my postmenopausal women, we know, we tell them it's not going to be covered. It's just you're
Yeah,
going to either have to pay out of pocket or let's talk about testosterone because physiologically testosterone makes sense for most of them anyway. So I usually kind of start that route rather than the medications for them.
and so how do hormonal changes biologically contribute to micro tears?
Oh, good question. So definitely we see micro tears in the vagina and the vestibule and in the vulva. But what I would say is what we really see micro tears or fissures. I mean, anytime I have a patient who tells me that she's tearing or bleeding during intercourse, I'm
Mm.
thinking about lichen sclerosis. So this is
Ah,
an autoimmune condition of the vulva. And for a lot of women before menopause, we don't see the characteristic signs or symptoms like the itching and the burning that a lot of women after menopause start to experience. But if they have tears or fissures, especially by the labial
yeah,
creases, then I'm thinking lichen sclerosis. But after menopause, for sure, these women need vaginal estrogen as well, because the symptoms are way worse. The tearing is way worse if they don't have estrogen on board, or intrarosa or something like that. And so sometimes there is narrowing of the vagina that occurs. And so they do need to use like a vaginal dilator or a vaginal trainer, something that's going to help to gently stretch the vestibule or the opening of the vagina, so that when they are having penetrative sex, that's not what's doing the stretching for them. And so it's not
Yeah.
quite as abrasive.
Yeah. What about lichen planus? That has some
Mhm.
tearing as well,
Yeah,
right?
definitely.
On the
There can be
outside
tearing
and
for lichen
inside.
planus as
Yeah.
well, for
Yeah.
sure. For some reason, I feel like I see lichen sclerosis more often.
Yeah.
I
I
don't know if
agree.
it's just my patient
Yeah.
population,
No, I
but
see that.
definitely lichen planus can have fissuring as well. And I don't know, it seems like a little bit easier to treat. I don't know why. We could ask one of our dermatology friends, but definitely the two issues for sure are things that I'm screening for when women
Right.
say that they're having tears.
Yeah, and I think that definitely, of course, we know that anything that's causing pain is going to result in vaginismus. So I'm sure you see like
Mhm.
lichen sclerosis and probably lichen
Yes.
planus, right? You have this
Yep.
vaginismus, which is, which makes
Yes.
sense, right? If you're having a lot of pain.
Right.
Um, so what questions should women be asking themselves before assuming their libido issue is hormonal, you think?
Oh, that's a good question. So I guess I would go back to asking themselves, what has changed, right? Has your libido always been low? Because I do have patients who say like they've always had a lower drive than their partner, or they just felt like even compared to their friends or their peers, they had a lower drive. And if that's the case, that might just be you, and that's not abnormal necessarily. But if you're noticing a change, that's where I tell women to kind of think through like what was happening even 6 months prior to that change. Has there been a change in your lifestyle? I have patients who are in really stressful programs. I'm kind of in a college area, so I have a lot of grad students who are in very stressful schooling programs, and these things come up for them and they are not connecting it to what's going on in their life, right? And all of a sudden they're having tense pelvic floor muscles, pain at the entrance of the vagina, or even and low libido as a consequence of all of that. But they're only thinking of it as a physical consequence. They're not thinking of what's going on in their life, that maybe this extremely stressful exam is causing them to tense their pelvic floor muscles, and now like for months of that tension not getting resolved, they're now having these other issues that it's at the end causing low libido. Again, any medication changes in those 6 months? Is there an issue with thyroid that you even know? If it's not for yourself, is it in your family? um, and then thinking through any other perimenopausal or menopausal symptoms that might be helping us to see that this is actually a hormonal change.
Yeah. You mentioned Esther Perel, and she talks a
Yeah.
lot about spicing things up, right? And not, right, monotony is what leads
Yeah.
to boredom in a lot of times a relationship. So, what practical ways do you think that couples can reintroduce eroticism when
Mhm.
desire dips?
So this really sounds basic, but I think sometimes simple is the easiest to integrate. This was suggested by a therapist colleague of mine who says, like, not only should you have a date night with the person that you want to be with, but you should have a date night where you kind of take turns being the one planning it, so that you actually
Mm,
aren't aware of like what exactly is going to happen. There's kind of this excitement that
yeah,
can come from people like kind of getting ready for something, getting dressed, and like having something where you're not the one planning it. Because I
love
think
it.
this also happens
Yeah,
for women if they
yeah, you
want
get
to have it,
tired
right?
of planning everything.
Exactly. For a lot of my patients, like if I suggest date night, they feel like, oh my gosh, that means I have to find
Another
the
thing to do.
babysitter.
Yeah,
I have to figure out where we're going to go. I have to make a reservation. I have to do this. But I think for partnerships, if you can say, like, this will make the intimacy more likely to happen if you plan this, then a lot of
right.
partners will
Like do
take it
some
upon
work.
themselves. Yeah, you do the work. Exactly. Right. And let them plan it. And you can suggest it as like we take turns. Like this week, I'll plan it, next week you do it. But then at least you're taking turns of like kind of putting in that mental work of thinking of what you're going to do, where you're going to go, and who's going to make all the arrangements. And I've found that to actually work for my patients, is that like it's so simple, and yet it allows the practicalities to be solved for, which is what ends up being the barrier for a lot of people.
I love that idea. I think that's such a great idea. I will actually say to, do something that increases emotional intimacy, right? So
Ooh,
you
I like that.
could, yeah, like you could take a walk, just simple things, even like you don't need a lot of money for this, right? Like you can
Yeah.
take walks outside, just holding hands, right? Or making a meal together, or hugging on the couch, or giving each other a 6-second kiss. I think the Gottman Institute talks about that a lot, about increasing intimacy by prolonging that kiss, or just sharing something together that means something, right? Just the two of you doing it together, which increases that emotional intimacy, which then allows the person to kind of get their mind ready for some type of physical intimacy, right? And I think that we haven't really talked about this, but the human sexual response cycle, right? That as long as somebody is open to some sort of sexual stimuli, that allows that arousal to happen. And then if when the desire is probably going to follow after, right? And that's what the whole idea of the responsive and the spontaneous desire, and knowing that in long-term relationship, responsive desire tends to be what is predominant. And then that's okay, right? Because if the arousal happens, then the desire comes after. That's still a good thing. So,
Totally fine. Exactly. Exactly. And sometimes it's just that validation, right? Just
right.
explaining what responsive desire is to people sometimes is what is helpful for them, because
Yes.
otherwise they're like, why don't I want it? What's going on? Right.
Yeah.
And that can just be all that they really need in terms of
Yeah.
treatment.
Yeah. I think also, when we talked a little bit about the eroticism, what I think is fantastic for that for individuals is sensate focus,
Yes, definitely.
because I think that, there's no goal in it, right? There's no
Right.
like you have to orgasm. Yeah. It's just touch for the sake of touch and for yourself. And it's for yourself to explore. And it could be by yourself, it could be with a partner. And
Yeah.
there's graduated steps to it so that somebody doesn't feel like it's too much too soon, right?
Right.
And
Exactly.
I think it's also good for those individuals that perhaps have never had sex.
Mm-hmm.
And so that
Yeah.
it gradually introduces them to touch, which I think is so amazing.
Yeah, that's really nice. Our psychologists recommend that a lot. And I know for some of my patients that are hesitant to go see a psychologist, I have found on Amazon or online, like you can find these workbooks where
Mm,
people can kind of like teach it themselves. So there are resources out there depending on what your
okay.
comfort level is. But if you look up Sensate Focus, I think you'll find sort of the gist of how to get started. And I
Yeah,
agree, it can be really helpful for people.
it's great. So, how do you think cultural or religious messages around sex contribute to midlife sexual suppression?
Ooh, what a good question. I mean, I think it's there from the beginning, from the time that we talk about whether it's intimacy or the way we talk about relationships. I think religion and culture is part of it. I grew up in a pretty conservative Christian religion, and we had like seminars at our church summer camps about like not having partnerships that were too close, because we would lose our own integrity from it. And like there's so much negativity about your body as like kind of giving into your fleshly desires or like things that are not godly. And yet, all of a sudden, if you become married, like then have all the kids that you can have and have all the sex that you want. And like this like disconnect, I think, is really hard for people who grow up in sort of a purity culture. And so what I see for women as they get into perimenopause and menopause and their body image changes because their body is changing and they feel like they don't have control over it. And then they have these like background negative baseline messages. It's like they go back to that. Like I have women that can tell you specifically people who had gone through a divorce and then were putting themselves back out there, and they're in their early 50s and decided to have intercourse and bled with intercourse because they had all these changes and they were not on vaginal estrogen. They had not been using dilators, right? A lot of anatomical changes had occurred that caused them to bleed and have a lot of pain during sex. And the patient told me, I feel like this was God telling me like that I should still be celibate,
Like
like
she was
not.
being punished, right?
Yes, it was like
Hmm.
punishment. Yes.
Yeah.
And she was
Yeah.
like in tears in my office, like, I'm too old for this. And I
Yeah.
shouldn't be, and that's what God was telling me, that I'm too
Yeah.
old for this and I don't deserve to have this part of her life. Like that's kind of what she was
Yeah.
interpreting that. And I was like, no, this is a physical thing that's happened and it's treatable. And you can be out there if you want to be, and you can experience pleasure if you want to be. And like it's all about just be understanding what has changed with your body and how to treat it. And
Yeah.
so I do think like those messages from the very beginning stick with us. And then, this isn't religion, but for culture, we look at the media, and most of the media portrays sexy women or
Mhm.
sexuality being with young people. Like,
Yeah.
thank God for Nicole Kidman, who is starting to change that narrative. But like, she is a rule breaker because we're not accustomed to seeing sexy scenes with people who are in their 60s or 70s, right? They're
Right.
usually in
Right.
their 20s and 30s. And so we subconsciously kind of think of sex as something for young people and
Yes.
not for
Yes.
older people. But my patients in their 80s tell me how important sex is still to them. Like, we're still humans. Like, we
Yeah.
don't stop wanting to enjoy the pleasures of life
Yeah.
after menopause.
I just want to applaud you for just
Oh,
saying something that I've done so many podcasts. Been doing it now for 4 years, and nobody has brought up that topic of women thinking that they're being punished, because that
mm,
is something that for highly religious people, whether
yeah,
it's Christian or Hindu or Muslim or
yeah,
whatever religion you are, right?
yeah,
That idea of thinking that something you did,
yeah,
right, maybe a mistake that you think in your head
yeah,
was a sin,
yeah,
right? Like a sin.
exactly, exactly. Yeah,
And so now, because you're having this bleeding, right?
yeah,
That you're being punished because
it's
you're a horrible
affirming that,
person.
right?
And why did you do something? And
Yeah,
it's like so punitive, right? Like you have
yes,
people
yes,
have these thoughts. I've also heard of women that have had abortions in the past, right?
yes, right,
And
right,
and then later on that are not able to have children, and they're like, well, this is my
exactly.
punishment
Exactly.
because
It's the
I had an
stories
abortion.
that we tell ourselves, and it's not, we didn't make it up. Someone told it to us,
Yeah,
and then our experience fed right into it. Like we were,
correct.
and yeah, it's, yeah,
That would be a great research paper on so
yeah,
many levels.
you're right.
That would be like, like sexual dysfunction
Yeah.
associated with like cultural and religious messaging. I mean,
Mhm.
I think that's a research paper right there.
Thanks. Thanks. No,
You
but
and
you're
I
right.
should
Like,
meet
I
on.
mean, the point that you're like making me realize in our conversation, I love this, is that there's so many different things that happen to us that affirm what we believe. Just like I was thinking, if you see a physician who tells you, like, just suck it up, because that person is not educated in helping you through menopause, it affirms already this belief that, like, there's no help out there.
Yeah,
And right, so like if we have these messages that are affirming us negatively, then we're not going to get the help that we deserve. And so like
100%.
how do we like overcome that?
Yeah.
Yeah,
It's with,
there's a lot to unpack
yeah,
there.
it's with, and it's with social media. And I feel like, you know
Yeah.
what? I think I'm going to make a reel about it.
Yes. Honestly, it's probably the most efficient way to
Yeah.
get that messaging
Yeah.
out there.
Yeah. Yeah. Like that, something about like, I think I'm going to say something like, you're not being punished. This is not,
Yes, do it. Yeah.
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 I think
You're
that's
totally
something that,
right. You're right.
yeah.
And then the other thing that's you said that has really stuck with me is was it, you were talking to your mom, that like your
Yeah.
mom said that she
Yeah.
didn't know what to say to you because no one had said it to you. So I've been thinking like, okay, how do we help moms out there, like
Yeah.
myself included,
Yeah.
know what to say when you
Yeah.
don't have a template?
Yeah. Yeah. No, that's, maybe that's another thing, right? Maybe that's
Yeah.
something that Ishwish,
Yes. Yeah.
tackles,
How to
right?
talk to your kids. Yeah.
Yeah. I think that's great.
Yeah.
Okay, so we are almost done, but I want to ask you
Yeah.
the number one misconception women have about a libido is, and these are just like rapid fire, like whatever
Oh
comes
yeah,
to your
I
head
love it.
first.
Yeah.
So the number one misconception women have about libido is, what do you think?
I think the number one misconception is that women's libido is lower than men. I
Yeah,
think I see a lot of women who have issues with their male partners not having as much drive as they do. And they, of course, they're not coming to see me for the same issues as the women who are experiencing low libido. But when they start to have a decrease in desire because of perimenopause or menopause, it really bothers them
yeah,
because they've always had a higher desire. And so, and that's regardless of testosterone levels, right? Like we know that probably that woman's testosterone is lower than the man's, but still her desire is higher. And so there's still so much that I feel like I don't understand about it. But that is probably the number one misconception that women
mm,
just kind of as a rule have lower libido.
yeah. I'm glad you bring that up, that women actually probably have a higher libido because women get shamed, right?
Yes,
Like
yes.
like if they want sex more than their partners, I've had patients come in and say that their husbands make them feel bad because, or they think that
Mm,
there's something wrong with them, or why do you want sex so much? And oh my God, this is not normal, blah, blah, blah. But it's not
mm,
true,
right.
right? And so we just have to know that, women can and sometimes do have a higher libido than their
Yep.
partners. And who's to decide whose libido is better and whose is worse?
Exactly.
And
Exactly. You're totally
and and it doesn't matter. Like, who
doesn't matter.
cares?
Yeah, it's not a competition.
Right, exactly, exactly. Now, what is something you wish every clinician knew about menopause and sex?
Oh, I just wish everybody knew how to do a good physical exam, one that doesn't hurt
Yes.
women, but can still figure out where the pain is coming from. I do think that there's so much about the pelvic floor that I have understood beyond residency. Like I had got a little bit of training in that in my residency, but I've understood so much more really from learning from my patients.
Yeah.
Um, and so I think being able to do a physical exam to really isolate what is going on is something I wish everybody could do or would know. And if they don't, I mean, just refer to people who do because there's so
Mm,
many of us out there. Ishwish is growing, our society is expanding, and even if you have to drive a little farther, just refer to someone who
yeah. Yeah.
knows this
I was
area.
like I always like to say that menopause does not equal abstinence. Like, you
Yeah.
don't have to be abstinent unless you want to be, right?
Yes. Yeah.
Mm.
You know what else I'd like to say now
Tell
that
me.
people are listening? Stop telling women just to have a glass of wine.
I know,
Like
right?
I made a social media post about like looking in our textbooks of like where it says to recommend have a
A
glass of
glass of
wine,
wine.
right? Because I have heard it from so many of my patients
Yeah.
that they have heard this from their OBGYN specifically that I'm like, if so many OBGYNs have decided this is the treatment, it must have been taught
Yeah.
somewhere. It must be written in our Williams gynecology
That's right. That's right.
textbook.
Chapter 5,
Exactly. And I'm
line,
like, what?
paragraph 2, just
Right? Like
have a glass of wine.
exactly. I'm like, it's not anywhere. And yet,
Yeah.
so I think because people don't know what to say, that's
Yeah.
what they say. Like, oh, relax. Like, have something
Yeah.
that's going to make you
Yeah.
relax. But that's so far from the right answer to give people. And
Yeah.
it can be so invalidating.
Yeah.
And again, like,
Really
coming
upsetting.
back
Yeah.
to the punishing thing, right?
Yeah.
Like, okay,
Yeah.
right. You have something that's going to make you feel not yourself in order to get through this because, yeah, you don't
Right,
deserve
because your partner needs it, it doesn't matter if you enjoy it, right? It's
right.
a duty, right?
Exactly.
Duty sex,
Yes.
right?
Oh my gosh. Is that a term? That's you should coin that. It is
Yeah.
duty
I
sex. Yeah.
yeah, 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 yeah. I think, I don't know if it's a term, but yeah, I've heard it once or twice.
It's
But
so
yeah,
true.
absolutely, with like purity culture and duty
Yes.
sex and all of
I've
this
had
stuff.
cancer survivors who have radiation damage to their
Yeah.
vagina that are just having regular weekly sex that is killing them, causing them so much
Mhm.
pain out of a sense of duty. And
Yeah.
their partners don't even know it. Like my
That's
patients have
awful.
told me they've tried to mask the pain because they
Oh,
don't want their partners to feel bad. But yeah,
awful,
awful. How awful is
awful.
that?
And so the most empowering thing a woman can do today for her sexual health is? That's our last
Look,
question.
look in the mirror. I
Yeah.
think if you know what your anatomy looks like and you're familiar with your anatomy, it is not easy for us as women, right? Men look at each other all the time in the locker rooms. Their stuff is just hanging out. It's easy to see. For us, like we have to like get into awkward positions, get a big mirror. Like there's a lot more work and effort, but just look once a month so you know what your labia looks like. You know what your clitoris looks like. You know what the vaginal opening of the vestibule looks like. Because if changes happen, you are the only one who
Yes.
really, really will know. And if someone came to me and said, I have this thing on my face that's causing me pain, and I asked them, well, was it there a year ago? And they said, I don't know. I've never looked at my face. Like,
Yeah.
how preposterous is that, right? But when I see patients who have like cysts or lesions or changes on their vulva, and if I ask them, like, have you noticed that that's been there or is this new? And they don't know
Yeah.
because we just
Yeah.
don't, it's harder for us to look. So
Yeah. Yeah.
that's my answer. Look,
It's
look at
it's
yourself in the mirror.
yeah. It's harder for us to look, but also,
Yeah.
again, I feel like that's where that shame and that stigma and like, in some cultures, you're not supposed to look at your anatomy, like it's bad and it's sinful. And
Yeah.
anyway, so I think that we
Yeah.
have a lot of work to do. I think that, there's a lot of myths out there, and I think that that's why it's up to us, right? And so many other
Exactly.
people that are doing the work
Yeah.
and to help educate and empower people and
Yeah.
women and people born with ovaries to help them to understand their bodies so they don't have to be shamed,
Exactly.
shamed by it. And I think that so important. But I have loved this
Me
conversation.
too.
I think you are absolutely amazing.
Oh
So
my
for
gosh.
everyone,
Likewise. It's
so
been great
everyone
talking to
out there,
you.
I'm sorry, what? I
It's
cut you.
been great talking to
Ah,
you.
thank
Sorry.
you. And for anyone out there that is like, oh my God, Dr. Pope is so amazing. I so want to be her patient. How can people get in touch with you? How could they
Sure.
make an appointment? And where can they find you?
Yeah, so you can look at uhhospitals.org and just search my name. I'm the only one at the hospital, Rachel Pope. And you can make an appointment that way. You can also follow me on social media at Dr. R. Pope on Instagram. That's probably the best one. I'm on TikTok as Vulva Doctor. And I try to keep my information up to date. I have a website called ourwomanity.com. If you have specific questions, I try to answer them because I think this is a big thing. Like we need more resources that are at people's fingertips. So you can submit a question and I will make a podcast or a social media reel to answer it for you.
Amazing. Well, this has been so wonderful. Thank you so
Thank
much
you.
for coming on. And well, this has been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you have any questions about your health, make sure you go speak with a healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.